Today we're going to be talking about the drugs that we use for intubation and what the internist needs to know about them. Intubation is often a stressful time as decisions need to be made quickly. While the internist is usually not the one actually performing the intubation, they usually know the patient better than the code team leader or the anesthesiologist. Thus, they should know something about the drugs that are being given and how the patient characteristics may affect those drugs. By the end of this lecture, learners should be able to understand the purpose for administering certain drugs for intubation, be familiar with characteristics of the drugs, including indications and contraindications, and be somewhat familiar with dosing for each of the drugs. For most awake patients we're going to intubate, we give two different drugs, an induction agent and a paralytic agent. The purpose of the induction agent is to put the patient to sleep. This prevents the patient from remembering the traumatic event of being paralyzed, and also blunts the conscious and autonomic responses to being intubated, which can lead to severe hypertension and tachycardia. The three most commonly used induction agents we'll talk about today are propofol, etomidate, and ketamine. When we're intubating a patient, we also usually give a paralytic agent to promote muscular relaxation. This makes intubation easier by relaxing the jaw and make it easier to see the vocal cords, and it also prevents airway reflexes such as gagging and laryngospasm. The two commonly used paralytic agents are succinylcholine and rocuronium. Propofol is the most commonly used induction agent in the operating room. You might recognize it by its characteristic white color. It works as a GABA agonist. The biggest concern with using propofol is its effects on the cardiovascular system. It produces profound hypotension through a variety of mechanisms. It is a direct vasodilator, and it also indirectly blocks the baroreceptor reflex to hypotension at the carotid bulb. It is also a mild negative inotrope and can decrease cardiac contractility. From a respiratory standpoint, it's a strong depressant of respiratory drive. This is the drug that killed Michael Jackson. Because of its effects on blood pressure, propofol should be used with caution in patients who are in shock or at risk of shock, such as septic or bleeding patients, and also in any patients who cannot tolerate hypotension, such as those with coronary disease, aortic stenosis, or carotid stenosis. Normal dosing for propofol is about 1 to 2 milligrams per kilogram, or 50 to 150 milligrams for the average adult. The next drug we'll talk about is etomidate, which is also a GABA agonist. Etomidate's main advantage is that it has stable effects on the cardiovascular system. It has minimal effects on heart rate, contractility, SVR, cardiac output, or MAP. Thus, it is a good choice for someone in shock, especially cardiogenic shock. It is also only a mild respiratory depressant. However, there is a concern that it can cause a dose-dependent suppression of the adrenal system. Several meta-analyses have found as high as a 20% increase in mortality among septic patients after a single dose of etomidate for intubation. Thus, it should be used with caution in septic patients, though it is still a popular choice for emergent intubations among these patients. Typical dosing of etomidate is 0.2 mg per kg or 10 to 15 milligrams for the average adult. The last induction agent we'll talk about is ketamine. Ketamine is an NMDA antagonist that you may be familiar with, as we also use it as an adjunct treatment for pain. In terms of its cardiovascular effects, it is a direct negative inotrope by decreasing the rate of intracellular calcium transit. Some studies show that this effect cannot be reversed with beta agonists such as epinephrine. At the same time, it directly stimulates the sympathetic nervous system, which in turn can increase heart rate, SVR, MAP, and cardiac contractility. Because of this opposing effect on the cardiovascular system, ketamine can have unpredictable effects on blood pressure when used for intubation. For most patients with healthy cardiac tissue, the sympathetic effects predominate and blood pressure will go up after ketamine. However, for someone who already has an underlying cardiomyopathy, or for someone in extremis whose blood pressure is supported by a high sympathetic tone, such as a trauma patient, a dose of ketamine can drop their blood pressure. While it still remains a popular choice for patients who are in shock, just be aware that ketamine can actually drop blood pressure. Typical intubating dose of ketamine is 1 to 2 mg per kg, or 50 to 150 milligrams for the average adult. Moving on to paralytic agents, the most commonly used medication for paralysis during a rapid sequence intubation is succinylcholine. The rapid sequence intubation is used for patients who are not NPO or who are at risk for hypoxia during intubation, basically all the patients who are being emergently intubated. Succinylcholine is a depolarizing neuromuscular blocker and works by activating acetylcholine receptors. With this widespread receptor activation, you will see patients fasciculate before they're paralyzed. It has a fast time of onset, about 30 seconds. This fast onset is useful in patients in hypoxic respiratory failure who may not be able to tolerate periods of apnea during intubation. It also has a short duration of action of about 5 to 8 minutes. This short duration is useful in patients who are potentially difficult intubations, as in the event of a failed intubation, the patients will soon start breathing spontaneously on their own. The most feared complication of succinylcholine is hyperkalemia, which will be discussed on the next slide. However, SUX can also bind nicotinic receptors in the heart and cause bradycardia. It also increases patients' intracranial pressure and thus should not be used in any patient with increased ICP. Typical dosing for SUX is 1 mg per kg or 50 to 100 mg for the average adult. Hyperkalemia after succinylcholine is one of the most devastating side effects of using this drug. Patients who are at risk for massive hyperkalemia are those who have upregulated acetylcholine receptors at the neuromuscular junction. Thus, when the drug is administered, they have a greater degree of depolarization and more potassium released by the muscles. Patients who should not receive succinylcholine include any patient with muscle damage through a burn or crush injury, and patients with neurologic disease resulting in denervated muscle, such as stroke, upper and lower motor neuron disease, or muscular dystrophy. These patients can see an increase in serum potassium as high as 5 points after a single dose of succinylcholine. Patients who have pre-existing hyperkalemia also should not receive succinylcholine for obvious reasons. Another relative contraindication is immobility. After 14 days of being bedridden, patients can have an exaggerated increase in serum potassium as well. Contrary to popular belief, end-stage renal disease is not in itself a contraindication to SUX. In fact, these dialysis patients can often tolerate hyperkalemia better than most patients. The other commonly used paralytic agent is rocuronium, which is a non-depolarizing acetylcholine receptor inhibitor. This blocks the receptor but does not activate it. The main concerns with using rocuronium pertain to its pharmacokinetics. It has a slower onset than succinylcholine, about 60 seconds. This difference of 30 seconds can be significant in patients who are already in respiratory failure. It also has a longer duration of action, about 45 to 60 minutes. This makes it a poor choice for someone who may be difficult or impossible to intubate. It is reversible with a new drug called Sugamidex, but Sugamidex is very expensive and not always available from pharmacy. The typical rapid sequence dose of rocuronium is 1 mg per kg or 50 to 100 milligrams for an adult. In summary, there are 3 commonly used induction agents used for intubation. Propofol, the most commonly used one, can cause hypotension. Etomidate has few effects on the cardiovascular system, but can cause adrenal suppression that may increase mortality and sepsis. And ketamine has sympathomimetic effects, but is also a myocardial depressant, and thus can have unpredictable effects on blood pressure. There are also 2 commonly used paralytic agents. Succinylcholine has a rapid onset and a short duration, but can cause bradycardia and lethal hyperkalemia in selected patients. Rocuronium has a slower onset and a longer duration, but can be reversed if needed. Thank you for watching this video. We hope it was useful and that you learned something that may someday help one of your patients.